All right, good morning, everybody. We're going to go ahead and get started. Welcome, everyone, to our annual Resident Research Day. Yay! It's so great to see everyone here in person to really celebrate our residents and the work that they've done over the last 4 years. As always, we're going to start our session with a faculty speaker, and today we're very fortunate to be joined by Dr. Jeffrey Tice. So Dr. Tice is a professor of medicine here at UCSF. He really leaned into the idea that UCSF stands for You Can Stay Forever by receiving his medical degree, internal medicine residency training, and clinical research training here at UCSF. He stayed on after that clinical research fellowship for a Birch Career Development Award. That's the Building Interdisciplinary Research Careers in Women's Health, and has really become a nationally renowned expert in this area and a clinician scientist. So his research focus is on breast cancer risk assessment, mammography density, and breast cancer screening and prevention. He is currently a co-investigator for a NCI-funded PO1 study to improve the breast cancer surveillance consortium models. The work there is to improve risk-based screening, incorporating genetics, artificial intelligence, and rational thresholds for recommending mammography, supplemental breast imaging, and prevention. He also does policy work on drug pricing and with the Institute of Clinical and Economic Review. And most importantly, he rides with the UCSF cycling team known as Team Menstrual Cycles. So he is here today to talk about the results of the WISDOM study, the Woman Informed to Screening Depending on Measures of Risk, which is this groundbreaking clinical trial that randomized tens of thousands of women to different methods of breast cancer screening. This is a really excellent study with important results that have really a huge potential to change the landscape of breast cancer screening towards a more precision-based model. So thank you to Dr. Tice for joining us today. And obviously, I am new to this, so I'm sorry that I did not know the second slide would be our land acknowledgement. So we are always starting our grand rounds with an acknowledgement of the traditional custodians of this land, and we thank the community for their stewardship and support.
Well, thanks so much for that generous introduction, and thanks for the invitation to speak here today. Team Menstrual Cycles wasn't said. I don't know if many of you know it. It was started by one of your colleagues. Oh, great! Most people know. So when we start the ride, we do a ride for MS every year, and we started was by chanting "Best Team Period." So I don't know if any of you here are riding, but you're welcome to join. We often have residents join us on the ride. So I'm using, as you can see, I'm basing my talk off of Dr. Esserman's talk at the San Antonio Breast Cancer Symposium this year. So if I stumble a little bit, she uses a lot more animations than I'm used to, but we'll try and get through this. So my disclosures here, grants, I guess the only company affiliation that I have is we're part of the REACH study, which is a liquid biopsy, one of the multiple cancer screening tests. But I haven't gotten any money from them, but I wanted to acknowledge that. And then ICER, and then I'm on the guideline committee for the American College of Physicians. So as you're probably aware, there are years of controversy around how to screen for breast cancer. Our guidelines, I didn't put up the ACOG guidelines, but all of the guidelines have some variation. There's no agreement, and it's very different from what's done in Europe. And yet it's all based on the same evidence, and evidence that was generated more than 25 years ago. So I just have a couple of the examples up there. So if we wanted to do the first randomized trial in breast cancer screening in 25 years, and we tried to make our eligibility criteria quite broad: women 40 to 74, no history of breast cancer or DCIS, and no bilateral mastectomy, but otherwise no restrictions. And our guiding principles were really that no woman would be screened less aggressively than existing recommendations. At the time we designed the study, the US Preventive Services Task Force recommendation was for the average risk woman start at age 50 and every 2 years. So that was our least intensive screening regimen. And then we went up to, as you'll see, MRI screening. And we wanted to minimize false positives by reducing number of mammograms, minimize interval cancers, minimize the cancers that actually kill women. The incidence or the mortality associated with diagnoses of breast cancer really go up when you get to anatomic stage 2B or higher. And so we wanted to make sure we didn't increase a stage 2B or higher cancers. And women with known hereditary mutations were screened according to the NCCN guidelines. And we tried to make them practical and scalable. We'll see whether we did that. So this is the general schema for the study. And I put this up here just to highlight a couple of things. We did a lot of education upfront before consent because some women decided not to be in the trial. But we really wanted women to make the choice to be randomized. So we educated them about the value of randomized trials, but they also were allowed to just choose to do annual screening or personalized screening. And the personalized screening, the risk assessment model, at that point, we knew of 9 genes that were associated with breast cancer. So we sequenced those 9 genes. We used version 2 of the Breast Cancer Surveillance Consortium model. That's really my area of expertise. I helped to develop that and have continued to refine that model. And it's a clinical risk prediction tool like the Gale model. Age, race, ethnicity, family history, biopsy history, and so on go into it. Really, the core, though, is mammographic breast density. And then we also use the single nucleotide variants or polymorphisms. We put a bunch of them together into what's called a polygenic risk score. When we started the trial, we had 76 SNPs, but as part of our trial design, we were allowed to refine our risk assessment tool. And by the end of the study, there were 303 different variants that we put together in a polygenic risk score. And then we tailored our recommendations in the personalized group for what age to start screening, what age to stop screening, how often, whether just to do mammography or to add some sort of supplemental imaging. And then we educated women about their risk for breast cancer. And then, so that's the same thing. And then we binned women into 4 groups. Lowest risk group, we, again, like the task force guidelines at that time, we said, you don't need to screen right now. You can wait until you turn 50. For average risk women, we recommended mammograms every 2 years. Elevated risk, we had them actually see a breast health specialist to discuss their risk with something called the Breast Health Decisions Tool, which has been refined here for 25 years or more. And guide screening based on that discussion. And finally, for women at highest risk, mostly women with BRCA1 or 2 mutations or the like, they also met with a breast health specialist, but we recommended annual mammography for them, alternating with annual MRI. So we recommended that they get screened every 6 months. All right. And our primary endpoints, we had 2 co-primary endpoints. The first was non-inferiority of the advanced breast cancer, so stage 2B or higher, and then that we would lower the rate of biopsy in the risk-based arm compared to the annual arm. So here is the schema of the trial again, but with numbers in it. I know it's hard to see about this, but they registered online. They were invited to be randomized, consented online. Amazingly, 61% of the women agreed to be randomized. This was something we're really proud of, the fact that we educated women and they chose to be part of the randomized trial, more than half of them. And we had done pilot work in order to get this study funded, and we had about that in our pilot work too. So we're glad to see that when we rolled it out more broadly that happened. And in the observational cohort where we allowed women just to choose what they wanted, 89% actually chose risk-based screening. So 89%, the vast majority of women really wanted to personalize their risk, understand their genetic and other risk factors, and tailor their screening based on that. So here I'm going to focus for the rest of the talk on the randomized trial, but I wanted to point out just in the observational cohort that most women wanted to get the genetic information. So it's really acceptable to women to do that. So here you can see the number of people in each of the arms. The highest, I just want to highlight a couple of things. I'm not sure I can do it. So the highest risk group was not a whole lot of women, 2% of the total women. The elevated risk was another 8%. So only 10% of women were recommended for more intensive screening, annual mammography or mammography with MRI. And the vast majority were recommended to get screened every 2 years. And then am I doing this? All right. And we did this mostly online. Now, we did have a few centers like the UC medical centers, but women could sign up online. Everything was virtual. And so we actually enrolled women from all 50 states. Over time, we initially, our clinical trial was not as diverse as we wanted. So we got additional NCI funding to bring on some sites with more race ethnicity diversity. And you can see by including Chicago and some sites in the South, we increased our enrollment of Black and African American women from 1.7% initially in the trial up to 17.5% at the end. We also increased the proportion of women who were Hispanic a little bit from 8.1% to almost 12%. So here are the initial results. This is all invasive breast cancers, really no difference between the two arms in overall cancers. But the risk screening worked, the risk assessment worked. You see women who were in the highest risk group had the highest risk for breast cancer. That's the number of invasive breast cancers over time in the highest risk group. And then elevated average, which was right along, and then lowest, the average was very similar to the overall risk in the women randomized to the annual screening arm. And here's our primary endpoint for safety. The blue dots represent our non-inferiority threshold. We were clearly much lower than that. So the p-value for non-inferiority was like 0.000001. So we clearly met that. And we almost actually showed that our risk-based screening was superior. We almost had fewer, we had fewer, but it was almost statistically significant, fewer 2B or higher breast cancers. And here's the risk for the 2B or higher breast cancers over time. You see the curves diverge. And the interesting thing here's the risk groups. In the highest risk group, we had no 2B or higher cancers. So we would have expected, based on the numbers, at least 5 2B or higher breast cancers. So by doing more intensive screening, we almost certainly identified those cancers earlier, and so when they were at an earlier stage, and treated them at an earlier stage, and hopefully in the long term prevented death from breast cancer in those women. Again, in the other risk groups, they were sort of stratified by our risk as expected, and there's the annual arm. All right. We also looked at 2A or higher. So the radiologists were still concerned about stage 2A cancers. And there we had fewer, again, the risk stratification worked, but we did in the highest group have some stage 2A cancers. All right, I'm going to go through that quickly. And the highest and elevated risk groups were above the annual group. And this is historical data in the United States from SEER in the in the 1980s here. That's when we started doing mammography screening. We saw a huge increase in early stage breast cancers. We hoped that would translate into a big reduction in late stage breast cancers over time, and you really don't see much of a drop. I see Rebecca, my classmate in medical school, shaking her head. She understands this well. She gives many talks about this screening, I know. But here in this trial, the risk-based arm, we saw an increase in early-stage breast cancers and a decrease in late-stage breast cancer. So that's what we were hoping to see. And here's just this graphically. Here is the stage distribution in the annual arm. So DCIS in stage 1 being low stage, and then the higher stage 2A and 2B here. I'm going to switch to the risk-based group, and you see the number of early stage breast cancers went up and the late stage breast cancers went down. Rates, unfortunately, they were similar in the two groups. In fact, nominally, in the risk-based arm, we had more biopsies. So we didn't hit the second co-primary outcome. You can see again, go back there, of course, the highest risk group had the most abnormal mammograms, the most biopsies, and so on. So I'll talk in a little bit in why that happened. It's really based on mammography. We did have fewer mammograms in the risk-based group, but not anywhere near where we should have. In the average, the annual arm screened less than they should have. They weren't getting a mammogram every year. They were getting a little less. And our average risk women who were supposed to screen every 2 years were screening much more frequently, more similar to the annual arm. So, again, we couldn't force women to do, and I think one of the weaknesses, and we can talk about this later, is we didn't work with the ordering physicians, the OBGYNs, the family practice docs, and I think that also influenced the discussions, and as part of the reason we didn't have as much adherence as we would have wanted to our recommendations. Genetic testing is feasible. This was done again across 50 states. So we mailed spit kits to women. They returned them, and most completed the genetic testing. One of the interesting things was, about 3% of women had a pathogenic mutation. And 1.2% were high penetrants. So high penetrants are the BRCA1, BRCA2 mutations. And those are the women that we recommend mammography. For the lower penetrants, just a modest increase in risk. Many of them, based on some other risk factors, we either recommended annual mammography or else MRIs if they had other risk factors. One of the interesting findings was that among those women who we identified as having a pathogenic variant, almost a third of them, 30%, had no family history of breast cancer. So it shows the potential value of population-based screening for, and I think, in all of your careers, we're just all going to be sequenced, probably at birth, and we're going to use that information. It's going to be built into the EHR. It's going to guide prescribing and things like that, and we'll learn about this. We're not there yet, but hopefully this is evidence that will support coverage for that going forward. In prevention, we had in the highest risk group, you can see the, actually this is among the highest risk group at baseline, and compared to during follow-up. You see those at highest risk increased their uptake of endocrine risk reduction. So this is using tamoxifen, aromatase inhibitors, raloxifene to reduce the risk of breast cancer. So we saw some increase, not as much as we would like, but the majority of women said that they increased their exercise, they worked on weight loss and actually lost weight, and decreased alcohol intake, all modifiable risk factors for breast cancer. So major limitation, I think, is that women didn't follow their risk assignment. Many already had been told to get screened more often, that they were at high risk, even though with our risk assessment, we told them they were at lower risk. But we hope that these results will give women more confidence in the future that it's safe to follow these recommendations. The other aspect was pragmatic. Across the whole US, it was much more challenging to get access to images themselves, image reports, pathology reports, but 95% of all the cancers were verified. And then we used registry linking and so on. And just to say that the biopsy rates were 4 times higher than the number of cancers, and this is the expected ratio that we see in observational studies. So we think we were capturing most of the reports of biopsies as well. Can we afford this? So here is one cost analysis of the ACR guidelines, where they recommend intensive screening for women with dense breasts with MRI. Huge cost. So we're talking almost $30 billion every year if people followed the ACR guidelines. And this, we actually varied participation rates. So we didn't even model out here 100% concordance with the guidelines. We used data, national data on screening rates and varied it by age. So the uptake would have been between 54 and 78%, depending on the characteristics of women. And we applied that across all 4 guidelines. American Cancer Society guidelines cost about half the ACR guidelines. The new task force guidelines would cost about $8 billion. And the risk-based actually would be the lowest cost, even incorporating the cost of genetic testing, the way we did it, sequencing 9 genes plus looking for the single nucleotide variants. All right. Yeah, and just in terms of drivers of cost, it's participation rates, the percent assigned to high risk, so those are the women who get MRIs, and then now the cost we've moved mostly to tomosynthesis, which has additional costs. I mean, we've added digital mammography from film, that added costs. We've now moved to tomosynthesis, that's added costs, and so that's partly why the costs have gone up from prior cost analyses. All right. So this is just a nice summary that JAMA put together in the publication. The key findings being the different rates of the aggressive cancers, the 2B or higher cancers. When you look at national statistics, so we still have about 320,000 new diagnoses of invasive breast cancer every year, and about 46,000 of those are 2B or higher. If we converted a third of them to lower stage disease, that should translate into a reduction in mortality of about 4,000 to 5,000 women a year at a lower cost and lower screening burden, fewer mammograms. All right. I'm going to conclude with Wisdom 2.0. One of the other PO1s we have is actually to improve the Wisdom risk assessment process. So we now know there are additional hereditary genes for breast cancer that have been identified. My wife was part of Wisdom 1.0 and 2.0, and Wisdom 2.0, she found out she has a gene that puts her at higher risk. And one of my daughters has it as well. So impactful. The BCSC model, we've improved it to version 3. The big difference there is we now incorporate BMI, which particularly for postmenopausal women is a really important risk factor for breast cancer and modifiable. And then instead of the 303 single nucleotide variants, we're now doing something called low-pass whole genome sequencing. So they do a few passes of the whole genome, and then you can get a pretty accurate estimate of all these different variants. So we now have one improved polygenic risk score for African American women, just was published by one of our collaborators out of Chicago. And we use over 100,000 SNPs put together for that polygenic risk score. And then finally, we're incorporating mammographic AI. Mammographic AI alone is better than any of the clinical risk prediction tools in terms of sorting out higher risk women from lower risk women. And so part of our grant is to refine all of this, but incorporating mammographic AI. It opened in 2023, and we already have more than 30,000 women enrolled in this study. And one of the big things is we dropped the risk assessment age to age 30. And that's because women who are BRCA1 carriers, they start to get breast cancers in their 30s. And so we want to identify them early if we're really going to impact their risk for breast cancer. So that's the thinking behind that. Clearly, most women we won't recommend screening, but the highest risk women we will. So conclusion, risk-based screening should become the new standard of care. And our guiding principle is more for those who need it, less for those who do not. The Wisdom trial offers a platform to continue to improve. Laura Esterman, who's the driving force behind this, is a big believer in continuous learning and continuous improvement. As we learn new things, update what we're doing. Don't wait to implement new knowledge. So I just want to acknowledge many co-authors. As you can tell, this was a huge project, lots and lots of funders. Takes a village, a huge number of study coordinators, the breast health specialists who are mostly genetic counselors who talk to the highest risk women about their diagnoses, the program managers, the advocates, community leadership board, a huge number of people involved. But of course, the biggest thanks go out to the women who agreed to participate in the study. If you want to pull up the clinical trial, the JAMA publication, it's there, but it's easy enough to get that. I see a few people pulling their phone out, so I'll wait a second. And with that, I'll take questions. Thanks.
Okay, so I see this going the way of cervical cancer screening, right? It becomes so complex that you have to get out your phone and like enter things in there to know what the next step is. And at the same time, of course, I support more for the people who need it and less for the people who don't. Talk us through how we could start to use this in our practice.
Yeah, no, the real challenge is implementation. So what we're trying to, I mean, the only, the first step in implementing this is the genetic testing. And so we're trying to work with companies that do this testing so that they would generate the risk assessment and recommendation. So they would actually implement the risk model, and that they would generate a letter for patients and a letter for the patients to bring to the clinician that orders their mammograms to help with that conversation. But to implement this, I think we can't depend on clinicians to be entering this and figuring out SNPs and all of that. It's way too complicated. We're also working to implement as much of this in the EHR. We're trying to work with Epic to get things in and so on. But it has to be automated, and we think the place to do that probably is the companies doing the genetic testing.
Questions about the genetic testing. So it sounds like this is whole genome sequencing, not targeted assessment of specific genes. And so is there?
No, it's actually a panel of genes that we sequence. So we don't sequence the whole genome, but then we do, as part of that, they do this thing called low-pass whole genome, and with that you can impute with high certainty most of the variants. So that's the, but it's not the level of detail that you need to sequence the whole exome or genome.
So there's not a concern that you could incidentally find variants associated with other.
Oh, absolutely. I mean, many of these things have other cancer implications, and the company we've worked with is Color. And for Wisdom 2.0, they didn't want to do anything custom with us anymore. So they're doing one of their panels that includes all of these genes, but it also includes the colorectal cancer genes. So we're getting them mismatched. So we have to do some counseling around that, but they actually have that built into their workflow. They actually have genetic counselors who reach out and talk to the affected individuals. So, my wife spoke to somebody from Color when we found that she had this mutation. So yeah, it's all, and right now it's relatively inexpensive. It's $250. So less than an office visit or a mammogram with interpretation.
Thanks. So fascinating. I was wondering if you could say more about the participation by race and ethnicity, and in particular, was there any differential, just like agreement to be randomized? And also, what else is being done with Wisdom 2.0 to try to increase the participation by Black and Latino?
Oh, I'm sorry. I guess I should be repeating these for the Zoom audience too. Sorry. So the question was about participation rates by race ethnicity, and I'm sure I don't have that off the top of my head. My recollection is that it was fairly similar, but I'll have to get back to you on that. I can't remember for sure. And in terms of enrollment in Wisdom 2.0, we're part of what we're doing is outreach to all the participants in Wisdom 1.0, but targeting those the non-white participants are the ones who are getting formal requests to join. Though many other people have just joined on their own, and we're continuing to work with the VA. The University of Chicago, and other sites that have more representative populations to ensure that we're getting that kind of diversity. And we're using what we learned from the NCI grant to increase diversity to support Wisdom 2.0. It's a really important core to our work. There are lots of other questions there.
Is there any interest in decreasing the screening frequency for women of lower risk now that there's sort of this more accumulated data?
So the question is whether to decrease the risk of lower risk women even less, to every 3 years. So there's a trial in Europe called MyPEBS, where they're recommending every 4 years to some women, no screening to some women. And we work with them in the design of their study, and we're sharing data and going to work with them. So we hope to learn how to do that. It's challenging. I actually look to what's happened with you all and cervical cancer screening as a guide. And it's been remarkable how we've changed from an annual for every woman to every 5 years for many women with co-testing, and the the evolution of self-collecting specimens now. I mean, it's been amazing what you all have done. It's really challenging. Many of the radiologists still, as you know here, we haven't been able to change the recommendations coming from mammograms at UCSF. We've fought for decades, literally, to try and get the recommendation off of the mammogram reports. But we still have a long way to go. We have a lot of radiologists working with us who believe in it, but it's challenging. But yes, we hope to get to a place where women at very, very low risk, we decrease the frequency of screening. I mean, part of what I didn't say is we update the risk every year. We want to have contact with women. Women have relatives who develop breast cancer. The risk changes over time. They may get a biopsy with atypical hyperplasia, which increases her risk. So we need to do that as well. Even if we're not recommending screening, we want to make sure that risk assessment is updated annually, which may be a challenge. We'll have to see.
Thanks so much. This was fascinating to hear about the evolution of the trial. I'm hung up on the genetic testing. That seems to be a necessary piece of the risk assessment. Did you look at it with leaving that out? Is there any way to leave that out and to still get a better tool than just standard recommendations?
Yeah, thanks. So the question is, if we didn't incorporate the genetic testing, which is a barrier, it's not readily available yet, how did we do? And we're actively looking at that, but it's an analysis that's ongoing. So I can't answer that, but we definitely are looking at that. Certainly there was just modeling that came out in JAMA Network Open, where they did risk assessment just using the BCSC version 3 model. They tested like 50 different screening scenarios and showed that you could reduce mortality and reduce false positives and the number of screenings by doing several of the risk-based approaches that they had. So there are definitely ways to do it just using a risk model like the BCSC model. We're also looking at the BCSC model at predicting not just all breast cancers, but the advanced breast cancers, because most of the risk factors, even the SNPs and the polygenic risk scores, they actually are better at predicting ER positive breast cancers, which tend to be less aggressive breast cancer. So we're trying to refine things to be able to predict the faster growing tumors. Those are the ones where traditional screening misses them fairly often. I have a cousin who just, she's in Connecticut, where the breast density legislation included mandated coverage of ultrasound for women with dense breasts. And so in August, she had a mammogram, she had ultrasound, nothing found. January, she had an 8 centimeter breast cancer. And she probably was high risk and needed to get an MRI. I don't think it would have been missed with an MRI. But our screening still misses fast growing breast cancers. Hard to get, or these single. I mean, I think when you do sequencing, you get it if you ask for the information. So I don't think I think there's a lot of interest in it, and even for the hereditary breast cancer genes, particularly the moderate penetrance genes like CHEK2, which is the most common variant that we found. There are risk models that adjust, that incorporate polygenic risk to decide, oh, this woman really is high risk and should be getting MRI screening. This woman is actually lower risk. She can just get mammography every year. So there's a lot of data in the breast cancer world with polygenic risk scores, even in those who carry a hereditary gene mutation that's deleterious. So I think it's going to stay in the genetics of breast cancer. But we can look at, and I will say some of our preliminary work looking at AI, adding AI, the polygenic risk score to AI captures almost all of the risk. Adding the clinical risk factors only adds a little bit more to the predictive ability. So again, we have evidence that if we're going to use AI, adding the polygenic risk score to AI actually helps a lot. So most likely in the future, that's probably the direction we're going to go.
Thank you so much, Dr. Tice. This is from our Dr. Robertson on Zoom. Why do screening recommendations stop at 75 when an early detection can result in decreased mortality?
So the question was, why does screening stop at 75? It doesn't stop in some of the guidelines. And in wisdom, I didn't talk about this, but we used a tool that estimates the risk of dying. And if a woman's risk of dying in the next 10 years was greater than 50%, we recommended that they stop screening. So we didn't use an age-based cutoff. We used a life expectancy calculator to guide recommendations. So one of the nuances here in the study, it's challenging, especially here at UCSF. I mean, I had a 96-year-old woman with critical AS who didn't want her aortic stenosis addressed, but she would get her mammogram every year because she would get the letter from radiology. It's crazy. So, I mean, there's a culture that needs to change. Again, we look to you. There's a lot of work. I mean, we work very closely with our breast cancer advocates, and we'll need to change the culture in the country over time. Physicians, patients, all those expectations need to change, and that will take a long time.
Thank you for this. Can you say more about what the AI is capturing that radiologists or other clinicians aren't? Is it features of the images that we don't know about yet? Or?
Yeah. So the question is, what goes into AI? We don't really know yet. I mean, thankfully, AI work these days is moving towards teaching us, oh, what are you picking out? And so that's an active area of research. Certainly, calcifications, microcalcifications is part of it. It was just something in JAMA, a daily newsletter today, highlighting that in mammograms you pick up arterial calcifications and using that for risk prediction for a coronary artery disease. So it can pick up a lot of different things, and calcifications is part of it. Patterns of density are part of it, but it's really not fully understood yet, but it's an area we're trying to work on.
Is there a plan for long-term follow-up to really assess any reductions in mortality with the more precise type of screening rate? Because to really demonstrate that the shift towards earlier stage is actually reflective.
Yeah, great question. Or is there plans for long-term follow-up? We're certainly going to try. It's a matter of funding and connection.